Hello, my name is Gwen, and I am the Director of Communications here at the UCLA Center for Health Policy Research. It's my pleasure to welcome you once again to our monthly Health Policy Seminar Series. Just a reminder that you can learn about upcoming seminars and webinars via our website, www.healthpolicy.ucla.edu. You can also sign up for our free monthly e-newsletter, Health Policy News, also on our website. And that way you will be the first to know about upcoming center seminars, data, and research. I am now very pleased to welcome our speaker, Dr. Lene Levy-Storms. Lene is a faculty associate here at the center, the associate director of the UCLA Boren, am I pronouncing that correctly?
Close, Boren.
Boren Center for Gerontological Research, and an associate professor in both the Department of Social Welfare at the UCLA Luskin School of Public Affairs and in the Department of Medicine, Geriatrics at the UCLA David Geffen School of Medicine. Lene is an expert on aging, provider-client communication, social support networks, health behaviors, and program evaluation. Her core research concerns communication issues between healthcare providers and older adults in long-term care settings. At the Boren Center, she focuses on applied research to improve the quality of life of older adults in long-term care settings. Lene comes to UCLA from the University of Texas Medical Branch in Galveston, Texas, where she was an assistant professor in the Department of Health Promotion and Gerontology and a fellow at the Seeley Center on Aging. She is a California girl, however, with an undergraduate degree in psychology from UC Davis and a master's of public health in biostatistics and a PhD in public health from UCLA. Please welcome Dr. Lene Levy-Storms.
Thank you, Gwen, for that very nice welcome, and Celeste for getting me lunch, and Steve for recommending that I be invited here. It is truly an honor to be able to come here to the Center for Health Policy Research, where I have been a faculty associate for a number of years. And this is an exciting opportunity to share in more detail some of the work that I've been doing related to policy. To start, I thought about what I would be telling you today, and because it's a bit conceptual, I thought I might actually end with the beginning. Begin with the end. And so I want to highlight where I'm going, and then we'll go back and get there. And to avoid logistics with my slides, I'm actually going to avoid doing that physically. My core research, as Gwen mentioned, is focused on communication behaviors between caregivers and older adults with dementia. And it is a very micro-focused type of research. But in recent years, I've gotten interested and involved in policy work, much more of a macro perspective. What I find overall is that there is a lot of momentum to improve dementia care, which I will be telling you about. There's also recommendations and requirements to train caregivers better to take care of persons with dementia care. But in the end, I will show you how some of these specific recommendations, the most concrete behavioral strategies that caregivers can use, are presented in a way that I'm not sure is going to be have the most impact on their behaviors. And it leaves caregivers perhaps wondering, of all of the laundry list of behaviors that I could use to take better care of a person with dementia, how do I implement those behaviors? So my policy interests are really in improving training the long-term care workforce, in particular for older adults with dementia, but also in general, and in particular for their communication or bedside manner while they're providing care. So that's where I'll basically end up. But now I'd love to tell you more about the story of my policy endeavor with the Dementia Initiative, where We are bringing humanity to long-term care. And I say we in the most broadest sense, because this is truly a national and even international effort. I just want to acknowledge some of my colleagues that have been instrumental in both participating in the Dementia Initiative, Karen Love and Jackie Pinkowitz, and then a number of other mentors and colleagues. One of my colleagues on that previous slide said that one of the blind spots that people have is seeing the distress, referring to when persons living with dementia have behavioral, act out behaviorally, is seeing the problem, is seeing the distress as the problem rather than as a symptom of a larger need. So they treat the distress and never get to the heart of the matter. And that is where I will take you, to the heart of the matter. How we can, as human beings, using our basic humanity, connect with persons living with dementia. And remember that although they may not communicate like those of us who don't have dementia, they're still there. Just to give a quick overview, I will briefly mention how dementia and its increasing prevalence is like a rising tide. I will also connect some dots, looking at different agencies and institutes that have been engaged in policy efforts around this issue of caring for persons with dementia. And then I will actually tell you exactly what the Dementia Initiative is. I will highlight the accomplishments that we have done so far. I will give you an update on our progress and some of the other dots that are up there. I will also describe what I think are just some, there are plenty more, but just some of the challenges that we face in making better policy for caring for older adults with dementia. And then I'll close with some next steps. So basically, Alzheimer's is the most common type of dementia, but dementia is really an umbrella term under which many different types of cognitive impairment and loss of memory function occur. It is a neurodegenerative disorder that has symptoms that affect functioning. Most obvious, the loss of memory, which comes on usually slowly and ends with literally the body forgetting how to do things, not just the person in their conscious mind. About 5 million Americans are living with Alzheimer's disease, and this is increasing rapidly. It's the 6th leading cause of death in the United States, and to this day, we cannot prevent it and we cannot cure it. I was shocked to find out that some of the drugs that are out there to improve memory functioning are temporary. There are over 15 million caregivers, and costs exceed $200 million in 1 year alone. So before I actually tell you about the Dementia Initiative, I want to highlight a few things that were going on prior that led to the forming of the Dementia Initiative and its goals. I also want to mention that there is a white paper that sums all of this up, so you can certainly refer to that for more detail. So in 2001, there was a prestigious Institute on Medicine report highlighting the quality chasm in healthcare and the need to take away a strict focus on medical issues and broaden the approach to care for patients. And this is revolutionary because the medical technology has progressed so much that we've almost forgotten about the person who delivers the care and the person who receives it. Then there was a campaign for quality residential care in 2005 and 6 by the Alzheimer's Association, where they sought to improve person-centered practices. Most exciting in 2010 was the Affordable Care Act and the Centers for Medicaid and Medicare Services and their efforts, of course, following the ACA. And the exciting thing about the ACA was that a ton of work went into getting into the requirements for training nursing aides that they be trained in dementia care. That was literally the phrase. And so CMS gets to interpret that and implement it. And there's also the impending societal challenges with dementia care, the unseen burden that is going on in the community, as by far most of the caregivers are taking care of their elders in the community. In 2011, the United States Senate's Special Committee on Aging had a hearing on non-pharmacologic approaches to dementia care in response to the overuse of inappropriate atypical antipsychotics that at face value people must feel like there's something that they do to improve behavior, but not only do they not work, they can be deadly. And then in 2012, the Health and Human Services started the National Alzheimer's Project Act, and that is the largest government-based umbrella effort to look at improving Alzheimer's care, and of course research and treatment and advocacy and support for caregivers. So, the Dementia Initiative. One of the mentors I highlighted in an earlier slide was Robin Golden, and she introduced me to Karen Love over lunch. She said we had a lot in common. Let me remind everyone that at this time, I was in the first year of a Health and Aging Policy Fellowship, funded by Atlantic Philanthropies and run by Harold Pincus. So we met over a golden lunch, and we formed a humanistic foundation in person-centered care. We had a lot in common about what we wanted to achieve insofar as bringing humanity back into long-term care. Karen has more experience in policy, and so she really led the effort to convene over 60 researchers, practitioners, and policymakers at leading age in Washington, D.C. And while we had already begun doing that, we were looking for funding. And very gratefully, one of several funders was the Archstone Foundation right here in Southern California. So we met in DC with over 60 people and noticed that these are from different types of backgrounds. It's not just researchers or practitioners or policymakers. We were all together, and that was intended. There we discussed and developed a consensus with 39 experts on strategies and practices for recommended dementia care. And that discussion that we had there only continued over email in the subsequent months when we began writing the white paper. Person-centeredness has become the heart of what the Dementia Initiative is advocating for. And person-centeredness has really blossomed into the policy spotlight. It is currently and has been on CMS's agenda for improving nursing home care. But what exactly is it? Well, it is basically the opposite basis for the development of the healthcare system that has traditionally been clinician and disease-centered. Healthcare reform requires CMS to fund services using person-centered care. And in taking this approach, person-centered care, we're broadening the approach to the health and well-being of a person to include not just their physical health, but as basic public health principles advocate their mental, cognitive, social, and physical health. And it's a recognition that the how of care provision and not just the what is equally important. And the roots are in humanistic psychology, and there you can find writings on the holistic and biopsychosocial approach to health. So, person-centered care has been talked about in a lot of different arenas. Still, it is somewhat difficult to define. You can get a feel for it, but it's very hard to define in operation what it is. So you really need a multi-dimensional framework for person-centered dementia care. And one of the biggest contributors in this area was Kitwood's work on personhood. And this is based in nursing, really highlighting the importance of the person. I basically took the liberty to say that this is a particularly at-risk issue for forgetting the person when we are working with persons living with dementia. It's similar to issues like racism, sexism, and ageism. Dementia-ism is misperceptions about the living personhood in a person living with dementia. And how that leads, those misconceptions lead to poor healthcare, actually discriminatory healthcare. In the nursing home, there have been studies showing that persons with dementia, the more advanced stages, they receive proportionally lower contact and care. So that has really contributed to reducing the standards of care, particularly for persons with dementia. So there's really a loss of individuality of persons living with dementia. We are basically at a loss for how to connect to the person inside of them when they are expressing themselves differently than what we're used to. So I bring in just a graphic to show how when we lose that individuality, then the person we're dealing with becomes blurred, just one of many. But once we understand what dementia is and how a person lives with it, we can begin to see the individuality in the persons that we're caring for, and perhaps begin to understand what a relationship can be, a caregiving relationship can be with a person living with dementia when we do respect their individuality and different ways of communicating. So the Dementia Initiative had these problems in mind and talk about these issues in the white paper. And then one of the main contributions of the white paper, besides setting up the problem and making concrete policy recommendations, is the contribution of a conceptual framework for how we can think about person-centered care in a way that is not tied to a specific context. It applies to both institutional care and community-based care. So each one of these core elements I will be going through, and the elements include core values and philosophy, structural elements, operational practices, and also ultimately personalized practice. To situate these core components of this conceptual framework, we use in the white paper a metaphor of a house. And at the basis of a house, you have, of course, the foundation. And that is where we have our core values. Then you have the structure of the house. And that is where we have structural elements that we conceptualize related to person-centered dementia care. Then we have the operational practices in the house, how the house starts to function as a system. And then ultimately, we see how personalized practices can occur in a home or in caregiving like they do in a home, and that the way we personalize care is really not according to what the institution needs are, but the person who's living with dementia. And that is really, the way we do that is based on a response to their behavioral expressions. Notice I'm using the word behavioral expressions. More commonly, you would hear of behavioral symptoms and problems associated with dementia. So this is really suggesting that we reconceptualize how we see the behavior of persons living with dementia. So now to go into more detail about the core values and philosophy. At the forefront, we say that you need to have not just relationships with people, but meaningful relationships. You need to know the individual as a unique person. You need to focus on their strengths and capabilities. This includes not doing things for people when they can do them for themselves, even if it's faster. Perhaps most importantly, for these other things to happen, you have to enter the world of the person with dementia, living with dementia. So really, it's like leaving your perspective in the world and going to how they are looking at the world. And that means not trying to reorient them so that they see things the way you see them, but actually you see things the way they see them. Okay, so structural elements that are embedded in this conceptual framework. Basically, because this framework is based on a systems approach, you must have systemic buy-in and support. And this is familiar to me because in my own research, as I mentioned, I focus very much on the front lines of caregiving. And colleagues have brought up, how can you do that without addressing the larger structural context? Isn't there a great danger that if you don't have that buy-in, then whatever you do at the front line is possibly negated by doing things the old way at higher levels? Well, that's a great point. I really can't argue against that, except that in the research world, we have to take a slice of the pie and not the whole pie. And so the best thing that I would say to that is I hope to collaborate with people who are addressing other components in the system so that we can look at everything at the same time. So the structural elements include relationships and community. Overall, that culture of a nursing home needs to be believing in these elements, that they're doing things to facilitate having meaningful relationships with the residents and their family. Also, it includes their governance, their leadership, their care partners, and the workforce. Nursing aides in nursing homes provide 90% of the care that a resident receives, but they are the least trained and the lowest on the totem pole. In other words, they have the least amount of power. So part of this is looking at how we can empower this workforce and bring them to the same level as governance and leadership, at least insofar as their ability to contribute knowledge about what is happening at the front lines. And then, of course, there are the variety of services that go along in homes. that people are not just existing day to day, living meal to meal, but we need to provide meaningful services that they can engage in. And that gives them a meaningful life and engagement. The overall environment needs to be tailored to the needs of a person living with dementia. This is possible more so in institutions and nursing homes than in homes, but even there, it has a long way to go. And then accountability. And basically, because CMS is implementing the Affordable Care Act's provision on dementia care, highlighting the need for person-centered care, they are also training their surveyors to be able to go out and identify these sorts of practices, particularly non-pharmacologic approaches to dementia care. That accountability is very important, particularly for institutional settings. And then the operational practices are what make the person-centered structural elements. And there, the structural element is relationships and community, but the operational practice is to ensure that staff and other care partners have time to build and maintain a relationship with the person who has dementia. Really, this is almost humorous, right? Because if anything, we know that in general, the healthcare system is pressed for time, and everybody is trying to get things done in less time. So this is an extremely tall order to say we need more time. But it needs to be out there, and it needs to be part of the framework to say, what do we need to do to achieve this person-centered care? Now, these specific personalized practices, that's where we get down to some of the very specific behaviors that can occur in making that house have the interior that fits the individuals. And at the top of the list is communication and relationship building. So this is recognized and advocated for in this white paper. Of course, family and friends. I was shocked in beginning to work in the nursing home over 10 years ago to realize that they really didn't have an area for family to have what I would say stimulating visits. Some have more than others, but ultimately there needs to be a more deliberate effort to make family feel like they have a role and a place to be there. There's also a need for commitment and experiential involvement. So it's not enough to just educate people about knowledge. We need to teach them on an experiential level how they can be involved in personalizing practices. And then there's person-centered dementia care knowledge and skills development, recognizing the need for more training. This needs to be modeled by leadership, as I've mentioned earlier, and overall nurturing these meaningful relationships that can develop from there. Now, one of the issues, particularly in institutional settings, is the same part of the workforce that spends 90%, provides 90% of the care to older adults. They're one of the least stable. There's a constant turnover. How can you develop meaningful relationships when people are constantly changing jobs? Huge issue. And that, of course, relates to consistent staffing, in which not all, but some homes will actually give nursing aides permanent assignments so that they can build that relationship. However, that's not always something that the nursing aides would be in favor of, because if they get stuck with someone that they don't feel like they can have a meaningful relationship with or don't want to, then they have to. And even more specific within these services could include things like activities, art, incorporating children. Right now, this is an innovative concept, and we have this at ONE One Generation in the Valley, where we have an intergenerational daycare. But older adults need to be exposed to different age groups, and children can be particularly good for that. Music, pets, social interaction. Interestingly, to have solitude follow that. But solitude is also good when it's chosen and enjoyed. And of course, related to that would be spiritual needs and practices, the use of touch. Think about how often people want to touch babies. Do you think there's that same propensity to touch older adults? Probably not, but yet that is so important and so personal. And of course, there's the basic activities of daily living that include grooming, bathing, etc. But to do these in a manner that is in accordance with what the preferences are of the person living with dementia. Also, therapeutic smells and light are important, and that all of these things need to be part of the regular quality improvement monitoring. So much it's improving, but so much of the quality improvement monitoring has been focused on task-oriented care, or basically paperwork, and really just accounting for, treatments was the other thing I was going to say, medication use and other sorts of treatments. We need to build into that more about the importance of person-centered care and what that actually means. So the white paper ends with some recommendations, some of which I'm highlighting here. And of course, we realized after having all of this consensus building that we were talking about high-level concepts that can be somewhat far from what do you actually do to implement and operationalize person-centered dementia care practices. And so part of that is we turn to the scientific literature to do a systematic lit review and look at what is the evidence for person-centered care practices and what are some of the benefits of person-centered care. And so this information can be part of our next white paper, and of course also an academic publication that identifies what it means to operationalize these things. And then establish a dementia advisory group of persons living with dementia and their caregivers. They also wanted to identify person-centered dementia care training resources. So really looking at what is out there that can improve dementia care and how can we make that accessible to the caregivers that need it so desperately. And also to create an open source process and network to broaden the input into the National Dementia Initiative effort. So one of the things that strikes me about being part of this initiative, and something that connects a dot with when I became a health and aging policy fellow, is that one important part of the policy process is gaining and building a network of people that are wanting to develop the change and have some sort of consensus on it. So really, while many of the ideas in the white paper are really just fundamental to humanity, it's how we put them together and the fact that we were able in the end to have most of those original 60 that sign on to the white paper, indicating a consensus around the importance of the concepts in this paper. So the dementia initiative has now turned into the Dementia Action Alliance. And it is continuing the efforts of the Dementia Initiative under a slightly different leadership team, and they also brought in other organizations like the Eden Alternative and Planet Tree that are also part of the core. And they're just continuing the mission of what we wanted to do with the Dementia Initiative. And then a few years ago, CMS in the Division of Nursing Homes, they implemented the National Partnership to Improve Dementia Care in Nursing Homes. And so this is where the training video that they have put on their website, I couldn't find it prior to this talk, perhaps because they said it would only be available for a year, but I'm not sure why. But basically, I remember being asked to give input on training people in how to use non-pharmacologic approaches to dementia care. And they also, as part of this initiative, set a goal to reduce the overuse of inappropriate antipsychotics by 15%. And I'll be darned, they reached it. And they're not going to stop there. And then there is the Health and Human Services National Alzheimer's Project Act, NAPA, which has an enormous scope in their activities, including the importance of improving the quality of care for people with dementia, but also things like finding a cure for Alzheimer's and improving treatment beyond just this medication that only lasts temporarily. So all of these efforts continue to build momentum and are an important part of the context that began with the Dementia Initiative. Okay, so I wanted to be realistic, because who's going to argue that bringing humanity to long-term care is a bad idea? It's a great idea. But let's be a little bit realistic. What are some of the challenges from a policy perspective that we face in continuing to pursue person-centered dementia care? Well, for one, semantics are an issue, because even within the Dementia Initiative, we really had to clarify how we were using non-pharmacologic approaches, or NP, with person-centered care, or PCC, with the general idea of dementia care. So there's a lot going on out there, but depending on who's doing it and who's writing about it, they take a particular stance on that. And so it's going to be difficult to keep everybody in the same path using the same terminology. Pedagogy is a really important issue. It, in my humble opinion, ultimately ends with where I began, saying that we need to improve the care with communication techniques, concrete behavioral techniques that caregivers can use. Well, there's an issue about what is the best way to do that. And it could be some of the traditional methods, such as lecturing or more experiential-based learning, or web training, which I actually highlight down here. The problem is that most of the training that nursing aides receive ends up being somewhat cursory, in the sense that, having gone to in-services to recruit them for my studies, in their hour of in-service, I'm lucky if someone's in there for 20 minutes, because they're coming in and out and signing in and signing out. Also, even their basic training, I was shocked to see that of the total hours that they needed to spend learning how to care, only 3 were dedicated to interpersonal skills, and then a few more about Alzheimer's care, but those were not explicitly linked. And all that really involved was reading a chapter in a book and taking an exam. So we need a better way to reach people that is efficient. That is really on the minds of policymakers right now. We need to be efficient. Technology is attractive for efficiency purposes because we can use the web, just like we are today. And that is very efficient, but is it effective? Can you really take out the face-to-face interaction, specifically when we're talking about communication skills for providing person-centered dementia care? And then there's the issue of mixing structure and operational recommendations and goals. Really, we're somewhat guilty of that in the Dementia Initiative because there's a lot of literature reviews out there about non-pharmacologic practices or person-centered care or dementia care. And there are both structural and operational aspects. But I think by having that all together, we risk losing the main message. We need to keep on target and know what do we want to accomplish with any particular policy effort. And then there's the common approach to separate institution and community. And basically this is referring to all of the issues we're dealing with in institutions when it comes to face-to-face for person-centered dementia care really carry over to the community. But often these settings are treated as if they're two different worlds. Also, if we want to document change, can we really believe that paperwork is capturing that? Or do we actually need to observe direct care and see that in action? Basically, I think what has been lost in some of the recommendations is overlooking what I would call the interpersonal synapse of direct care, where the care takes place. If we can work on that, then it can also spread to higher levels in the system. So the Dementia Initiative, with the funding from the Archstone Foundation, will also produce a policy brief based on the white paper and a manuscript for publication. And in my professional membership with the American Public Health Association and the Aging and Public Health section of the American Public Health Association, I will be working with colleagues to develop a policy statement within the APHA policy process, with the ultimate goal to have APHA keep that in their reserves when they are consulted on policy issues related to dementia care. And also, how can I best identify a policy lever? That was something Harold Pincus talked about in our health and aging policy program, where if you want to make change, aside from building this network, what is the best stance? And of course, I've told Harold about my belief in needing more concrete, experiential, interactive training on communication for person-centered dementia care. And he basically suggested that another angle I should consider is taking or putting forth what are benchmarks that different training programs need to achieve, and that providing those benchmarks can improve the way people are being trained without necessarily mandating that everybody use the same training curriculum, which just tends to not go over very well in the policy world. I have ongoing research that is also funded by the Archstone Foundation to provide more evidence for the effectiveness of training caregivers in communication techniques. I'm also working on a policy project that are demonstration projects that were mandated through the Affordable Care Act and being implemented by HRSA, NAHA, and PHCAST, which are basically nurse aides and home health aides, and also personal home care aid at the state level. Aren't those interesting alphabet soups? And so these two initiatives or demonstration projects are basically funding different approaches to training this part of the long-term care workforce. From a policy perspective, I want to look at what those curricula contain and try to make recommendations for what are these standards that Harold Pincus mentioned. And last but not least, in my research, I have had the good fortune of working with my colleague Susan Kohler, a speech and language pathologist and author, in which we've created a program called Get Connected. And it is a training program for caregivers that not only teaches communication techniques, but it teaches it in a way that makes sense and gives people an ultimate goal. So I pull this out of a lit review that was by the Alzheimer's Society, and they recommended guidelines for care, and I'm almost done, that they say in their recommendations, use simple words and short sentences in a gentle, calm tone of voice. Address the person by name. Make sure you have his or her attention before speaking. Allow time for the person to respond independently. Be careful not to interrupt. These are very important techniques. But how does reading a laundry list of these things translate into actual practice? And that's where our program offers one way to perhaps put that all together into specific strategies that ultimately end with an emotional connection with the person living with dementia. So in essence, we're back to where we started, where bringing humanity back into dementia care is really about honoring the person. But this doesn't come naturally. We need skills as to how to relate to them, and we need an effective way to learn those skills and put them in practice. That's it. Thank you.
Does anyone have any questions?
Yes.
I have a question. Sure. I found that really interesting, and I was just wondering if two things come to mind that I was wondering if you could address. The first is thinking on a broader scale. It reminded me of the discussions that are going on around behavioral care and behavioral techniques and dealing with people with autism as well. You know, usually younger people, not usually older people, but in similar kind of conditions where, you know, it's their own world and you have to live in it to be able to reach them. So I was wondering if you could talk about kind of the applicability of this concept to possible other areas as well.
And Lynette, if you could just summarize the question for the benefit of our online.
Right. What's your name?
Shayna Lavaretta.
Shayna.
I'm one of the researchers here.
Great. So Shayna is basically asking that there are probably other similar efforts, in particular in dealing with autistic children, different age group, and yet probably some of the same sorts of issues. And so how does that relate to what I've been discussing?
Yeah.
Did I get it?
Right, do those techniques translate over to not just this population in specific dealing with elderly with dementia, but also it seems like they're usable in different situations as well.
Yes. Well, that I would say is definitely true, that we do definitely make it explicit that at least Susan and I do in our program, that the techniques that we're teaching caregivers are not dependent on a particular context. It can be in the home or in an institution. In terms of other populations, I think you bring up a great idea that it could also apply to other caregiver, care recipient situations of any age where it is difficult to get in touch with the inner person. And so the communication techniques are really even things that we could use when you don't have dementia, like on your spouse or your coworkers. Imagine the first most important strategy that we talk about that was in that list was get their attention. Sometimes that's hard with persons without dementia or autism. So absolutely, there is an application of what I've been discussing to other arenas. Just like person-centered care is really something that the Affordable Care Act is promoting in all of healthcare. It's not just persons with dementia. Part of the catch, though, is that you have to know that there's a person in there. And that's where that dementia-ism comes in, because people assume that if they can't remember what they did 3 seconds ago, then maybe the lights are on and nobody's home. But that's not the case.
I have one other question.
Sure.
So this is more of a personal story. In San Diego, my grandfather ended up having Alzheimer's in his mid-80s and passing away about 85. And my grandmother took care of him at home as long as she was able to. But then my mother, who works in mental health and healthcare in San Diego, found a facility for him in San Diego that specializes in Alzheimer's care and had things like walls of locks, because evidently people with Alzheimer's really like to undo and do locks, and something that they could just do as a project. And they would have open doors at night so that people could get up and wander if that's what they wanted to do. It was very patient-centered. I was really amazed by the level of care that was offered at this very specific facility.
Mm-hmm.
And I was just wondering, how common is that? And are there more facilities like that, or is this something that was really kind of restricted to a small thing?
Mm-hmm. No, that's a great question. And what you're describing are some of the environmental, the personalized practices that can be related to environment. And I don't have an exact statistic on how common that is, but I can say that there has been a tremendous effort and progress in the last couple of decades to incorporate a holistic approach to providing a stimulating, appropriate environment for persons living with dementia. And that some homes are being built from scratch like that, and others are being adapted. They call this like Edenization, putting in plants and animals. So all of that, I think, is in the front of people's mind when they're building new facilities now, but there are still plenty of facilities that are not fully Edenized, or just have some of those things and not others. So it really is complicated because there's so many layers as to how you can reconfigure the environment to be optimal for a person living with dementia.
We have a question from an online viewer.
Sure.
Is Get Connected available to family members, senior community advocacy organizations? What is being done to increase community awareness?
Okay, was the increased community awareness related to Get Connected, or are those several questions? I don't know. Well, let's start with Get Connected. Get Connected is not currently available for like people to purchase and do on their own. What we're literally in the signing, ink mode of finalizing our license and relationship with UCLA's Office of Intellectual Property, and forming a company, an LLC, so that at the cost of covering our costs, we can make available licenses for purchase. But rather than just hand that over like a software, it is a program that either we need to train you in a train the trainer sort of way, or work directly with caregivers and train them. And so that's why one of my next steps is to really disseminate that and make it more available. But it's really taken over 10 years to get to the point where we have a complete program that is part of a toolkit, basically. So we're very, very close to being able to make that available in one of those two ways. Gwen, what was the other question?
What is being done to increase community awareness?
Okay, it's a broad question.
Maybe community awareness of the program? I think that's what she's saying.
Okay. So we basically have been reaching out to people, like, for example, here at UCLA, there's the Alzheimer's Dementia program that's being run out of UCLA Division of Geriatrics by Dr. Dave Rubin, and reaching out to their liaisons with community agencies to offer awareness of this program. We have conducted different workshops. Like last year, we went to the American Association for Geriatric Psychiatrists by invitation to do a workshop on this program. We've also gone to Michigan and done the program for actual caregivers, not just promoting awareness. So basically, we're doing whatever we can to increase community awareness, and even this is part of that.
Any other questions?
Yes. Thanks, Linda. This was a great presentation. I'm interested in your thoughts about care planning in the institutional setting, because there are CMS regulations that have been finalized in home and community-based care around care planning, and all of a lot of the ideas that you were putting forth for recommendations. I'm just wondering if there's specific care planning that's existing, a process for care planning with people with dementia and maybe involving their family members. What's the landscape in nursing home environment for that?
By admitting that I may not know exactly what those, care planning policies are, I am familiar, in general with them. And I would say that the things that are new and being modified in care planning in institutional settings are on target, meaning, they're touching on the right issues, like individualized care, like involving the family. But every time I see something, I worry that at the end of that effort, there's still this cliff that caregivers have to figure out, how do I take this good idea and make it into actual practice? And so those are the concerns that I have, is that are we really making that link at that interpersonal synapse of care so that the caregiver knows how to take information and skills and apply them, whether it's at that direct care or even in higher levels of care like care planning. How do we make sure that it's not just on paper?
Okay, is that it? Thank you so much, Lily.
Thank you.